Life comes at you fast. You look up and your youth has passed. The trade-off is you gained a little wisdom.
This is Adriana in Long Beach, and Allison Evers is away today. You're listening to Girls Gone Menopause. Our special guest today is Judy Wei. This is a pre-recorded interview we have with her. She is an OBGYN in Irvine, California, and a former professor at the Keck School of Medicine at USC. She's going to be talking to us today about issues related to menopausal women and the treatments that they can get. She has an operating theater in her office when you visit her in Irvine for any treatments that require surgery or minimally invasive treatment. She can do them right there in her office. And if you are interested in learning more about the treatment ALMI that I got so I could stop peeing on myself, she gave it to me, and I have a video deep into that I will link to in the show notes. This is Adriana with the Girls Gone Menopause podcast, and today we have an expert guest, Dr. Judy Wei, whose office is located in Irvine, California, and she's going to talk to us about some of the issues, medical issues related to menopause. Dr. Judy Wei, welcome to the show.
Thank you, Adriana. Thank you for having me.
So just
Hi, everyone.
Full disclosure, I used to work for Dr. Judy Wei. I completely recommend her as an OBGYN. And this is going to sound crazy. I used to work for her. She actually fired me. I still recommend her to people because her doctoring is excellent. If you're pregnant, if you have issues with menopause and you live in SoCal, I still say go to this woman. She is top notch. She is meticulous in all of her treatments that she recommends. She studies them all. She really looks into it. And you are not a client, you are a patient, and she is patient with you, listens to you, and wants to give you protocols and treatments that are going to deal with your particular issue. You are not just a number in her lineup, so I really recommend her. Dr. Wei, please tell us a little bit about your office and your history. Tell us a little bit about yourself.
Well, first of all, I love Adriana. We go way back. But Adriana's, we've always stayed connected, and you're always giving me a lot of updates on what's going on in the world. And I really appreciate that. And it's such a pleasure to hear that you're doing this podcast, such a important topic that I think women neglect to talk about, maybe not on purpose, but I think because there's not a lot of information, or the source of information may be hard to find, or if you're trusting your doctor, you're seeing your doctor, but then they're very busy, they may not have the time to go over in details hormones, because menopause, hormones, all these are very, very big topics. And that leads to what I do. I'm a OBGYN, board certified OBGYN with a subspecialty in minimally invasive surgery. I was trained at USC Medical Center, and I stayed on faculty for a couple of years. And I realized that I wanted to go into private practice, kind of with some encouragement from my husband. He said, I think you'll really enjoy having your own practice, kind of deciding how you want to treat your patients. And to me, that really resonated. And so it just kind of led me into the private practice world. And I'm an OBGYN. I'm very busy in OB and GYN for the first several years of my career. But then over the years, I realized that I couldn't really address a lot of the problems that my patients have. And so throughout the years, my mission had became to look for solutions that typically are not that people don't have good answers for. And that really drove me crazy. That really drove me to the point where I feel like, that needs to be a goal, is to find ways to treat these problems that we hear over and over, that we as doctors try to kind of not talk about anymore just because we don't really have good answers. And so that really became the model of my practice. So my practice is kind of a unique composite of different things that ultimately revolves around women's health. And because I take care of a lot of pregnant patients, what ends up happening is after pregnancy, there's this huge period of time that people just, you get a lot of attention and care during prenatal care and pregnancy and delivery. And afterwards, it's just annual exams. Oh, you're here for a pap smear. Oh, you're here for a breast exam. And then you hit menopause. All these years, people don't actually talk about what women go through. And we just attribute it to aging and maybe life changes, kids, husband, work. And so then my biggest project, and that's why our clinic is here, is we're trying to figure out what are women suffering from that maybe we can get ahead of time and preventatively take care of these things, and then find really good solutions that may not be available to most women. So in a nutshell, it's a very woman-focused comprehensive care. That's how I would describe my practice. And so anything from urinary leakage, from vaginal dryness, vaginal laxity, difficulty with sexual function, menopausal changes, to cosmetics, to people not satisfied by their melasma, stretch marks, hair thinning, skin laxity, their bellies, they have this post-mommy belly. All these things to me is what we do. So
fantastic explanation, and I'm glad that you went into detail. So I want to ask your medical expertise on two menopause-related subjects that have been in the news as of late. The first one is that the head of the Trump administration's Health and Human Services, RFK, decided to take the black box warning off of HRT, hormone replacement therapy. Dr. Wei, can you please explain to us what HRT typically comprises of, what that black box warning was there for, and what your medical opinion is on it being removed?
Well, I'm glad you brought that up, because HRT basically stands for hormone replacement therapy. And as we all know, hormones are very important, but people actually associate hormones just really with what? With when you're hormonal. You call someone hormonal, it's because they're so like emotional or hectic. So teenagers, they go through a lot of hormonal ups and downs, roller coasters. Pregnancy is very hormonal. And then menopause, right? But then after menopause, it seems like, okay, you hit menopause, okay, you're done, bye. No, it's what we need to sustain in life. Our body needs hormones. So when you're in your mom's belly, hormones dictate so much development, the cellular development, your environment, how everything works is a lot to do with hormones. Every stage of a woman's life, hormones are so critical, but then they're in different levels, they're in different balances, and in pregnancy, how to maintain pregnancy. But most people really focus on hormones as a deficit when they hit a period of time when their menses go away, right? You're afraid that you have too many menses or it's very annoying. So you're concerned, you see the doctor. When you don't have it anymore, you go see a doctor. So menses to us, it's so ingrained in women's health that, once it's gone, you're like, okay, there must be something wrong. But most people don't realize that it started way earlier. So hormone replacement is actually, it basically means giving back what you're missing. such as you're lacking vitamin D, so you give back vitamin D. You don't have enough thyroid hormone in a hypothyroid patient, so just giving back what your body needs. So hormone replacement has not been a new concept, but people have been very worried about hormones ever since the huge study, the Women's Health Initiative study. And that study was a landmark in hormones because it's a great study in the sense that finally people started to look into hormones. But it's also a really bad study, not because of the study, but what happened at the very beginning. So Women's Health Initiative, when it first came out with its preliminary results, it basically said hormones are going to cause cancer. Okay, so if you're a woman and you're on hormone therapy, you hear that you're going to stop hormone. If you're a doctor, you hear that you're going to stop giving hormones to your patients because of liability and you're putting your patients at risk. And why did that happen is because everyone was on hormones before that. Doctors would give it like candy. There's really no, it's not very strict. Everyone was getting it and everyone felt really good, but then they realized there are some complications. And so what happened is the press is always looking for news, right? They're not going to report something boring, right? Something that's safe, oh, it's not boring. Something that's sexy, that's harmful, that's exciting news. So when you have something that says something like a vitamin D is ultimately bad for your health, that's going to be big news. So when the study first came out, there's some preliminary data that suggested that hormones are going to increase a woman's chance of cancer. And then, so that data came out, that news came out, so everyone stopped. And then the data gets more refined. And as there's more data, there's more interpretation, then you start to see details. And the details show that it's not that it's the hormones per se, it's what type of hormone. How do you give it? What age are you giving it to? That's all very critical. What are the risk factors? And then they found that actually hormone is actually very, very safe, but you got to pick the right type. Okay. And then so that kind of went into the bioidentical hormone and what's synthetic, what's bioidentical, right? So then the study ultimately boils down to estrogen is safe. Okay, people think of estrogen as, oh, it's going to cause breast cancer. It's going to cause a stroke. It's going to cause cardiovascular disease. And part of it is kind of true. In the right patient, it's very safe. But when the study was done, they added estrogen and a progestin. And people just call that progesterone. And progestin is actually a synthetic form of progesterone that does not look like our own progesterone. And so when you give it together, and versus if you just give the estrogen, they found out the group that had progestin had a higher risk of breast cancer. Okay, so it was the progestin, the synthetic progesterone, that really puts you at a high risk for breast cancer. And so when that data came out, I'm sure it was on the news, it was in the press, but it's not as exciting. It's probably some little piece on the side that no one really paid attention to. And so then you have to rely on your provider to really get that information back into their system and start to deliver that message to their patients. Or patients, maybe nowadays there's ChatGPT, there's everything you can look up, but then there's a period of time when people don't know, right? So then you're deprived of your hormone replacement. So that's really why the black box warning and all these caution came about. But then the good news is, I think more and more patients are now more educated. Doctors are more educated. We also rely on AI and ChatGPT and all that to help us out too, right? Because our brain isn't as good as a human's brain can be. But then that allowed us to give more correct information for our patient and to give them, what the hormones benefits should be, and really pick out the patients that cannot have hormones or should not have hormones or have to be really strictly monitored to be on hormone. Then you're best treating the patients that way.
Okay, that makes perfect sense. So basically, when a patient walks in, the doctor has to evaluate them in particular to see what hormone protocol would be safe for them and what hormone protocol would not. Can you tell us a little bit more about what goes into that evaluation?
So hormones can be complicated because the way our hormones work, they're all interactive. Not one hormone governs everything. When one hormone is low, it may make another hormone higher, and vice versa. There's a lot of feedback mechanism that our body uses to adjust so that our body stays in balance. And so ultimately, our body's function is to keep it in a balanced, not skewed fashion. So homeostasis is the term that we use all the time, is that we're always trying to kind of go back to how we're supposed to be. So then if you're giving a lot of this hormone, it actually can affect potentially another hormone. So in patients that come in, we go through their whole history. Okay, do they have any medical problems? Do they have any family history that should be looked into? Their symptoms are very, very critical. A lot of the times, people that come in to ask about hormones, they've already experienced enough symptoms and probably looked up something or heard from a friend or a neighbor or maybe saw something on the TikTok ad or something that made them interested to know more about hormones. And then they start to realize, okay, my symptom that I've been experiencing for 5 years, for example, are maybe related to hormone. But then you have a bunch of patients that do not even know that. Okay, they come to you maybe just for annual woman's exam, for a pap smear. And if the questionnaire at your doctor's office isn't trying to pick up problems that may be there that's not really identified, you're going to miss out on things that could help you 5-10 years later. And also even immediate to make you feel better. So it's really a large population of patients that actually should be on hormones. They don't know that they should be on. They don't even know what that is. And so there's a huge gap of misunderstanding or lack of understanding of what your body needs. So then then really the patients that are already coming to you, it's a skewed and it's a small group of patients. But symptoms is key because everyone's threshold is so different. I may be born with always a low level of testosterone. That might be my baseline. Someone else could be much higher. So for me, if I drop any lower, it may look like there's nothing, but to someone else, and I don't feel anything, to someone else, if they had that big drop, they would feel horrible, right? So everyone's threshold for disease, for symptoms is going to be very different. So then when you ask symptoms, you can ask them to see if they're noticing over the years fatigue, brain fog, decrease in sexual desire, weight gain, all these things that are kind of vague, right? They're not things that may bring you to the doctor's office. It's not like you have a broken arm, you have abnormal vaginal bleeding, you missed a period. These are things that will bring you to the doctor's office, but not the fatigue per se, if it's not severe. It's not the central belly fat. It's not a little bit sleeping, not so good. Definitely it's not like not wanting your husband to touch you. Like that's something where you're like, everyone has that, right? So people actually don't talk to their doctor about that unless it's either brought up or they think that their doctor cares about this. Because most of the time, if you don't have a treatment for someone, you kind of don't want to know, because then you feel bad, because as a provider, you're supposed to solve their problem. But then if someone tells you something, you're like, okay, tell me what you have, but then you have no solution. It's worse, because then the conversation just goes nowhere, right? And you feel even worse. So I think that's the thing is people don't bring it up. But symptoms really dictate how this person may benefit from replacement. But I always check labs. because you may be that person that may not have that identifiable, very clear-cut symptom, you know, symptomatology, but then you may realize it when you see your labs be very off. Then you start to say, I do have that. But then I thought that was normal. I have so many women tell me that. Oh, like I'm feeling fine. And you check their hormone, you're like, you know, your level is really off. And they're like, you know what? I've been feeling much worse over the past 5 years. But 5 years is it's more than a bachelor's degree. Are you really going to notice that on a daily basis? Not really. But if you really go back and compare, you're going to be thinking, oh yeah, I was able to do this. I was able to get up early, sleep well, feel more energetic, have a positive outlook on things. Now I'm just like, maybe I'm just jaded. Maybe I have things at home that's really weighing me down. So they don't really connect the dots. So the symptom and the labs are still very critical. So that's my evaluation.
So I like the thoroughness of that evaluation with talking to the patient, listening to the symptoms, but then also doing the labs. So is the time to start doing that menopause, or is the time to start doing that perimenopause?
So what's perimenopause and what's menopause? Menopause has a definition because in medicine, if you don't have a definition, it's hard to label it. You can't put a label on something if you don't have a clear-cut definition. So, but we all know nothing is that black and white. But you have to have something arbitrary somewhere. So then they say, okay, menopause means a woman do not have a period for 12 months. Okay, so that's, and then by the time you hit that 12 months, you're menopause. I mean, that doesn't really make sense because I have a woman that says, well, it'll be 12 months in like next week, but I started bleeding. So is she not menopause? It's like, it's not Cinderella, you turn into a pumpkin or at a certain time. So it's not that clear cut. But menopause has that definition. But perimenopause, what's perimenopause? Perimenopause means around menopause. So before menopause, for many years, our body is going through changes. And it's going to go through all that change until, boom, you hit technically menopause. And then you have the post-menopause, which is even funnier because what does that even mean? That just means you're the rest of your life, right? You're post-menopause, right? It's like, okay, we got you a diagnosis, bye, we're done with you. No, it's just, then are you going to support them? What are you going to do after menopause? It's not that you treat menopause, you got to put it into a spectrum. So where are you on the spectrum and how do you help this person at different stages?
Got it.
So you're right, is that most people will go to the gynecologist when they hit some kind of menopausal issue. Most people will have what? They'll have hot flashes. They'll have night sweats. They can't sleep well. They may get really irritated that maybe the husband will bring them in. Be like, help my wife so I can be helped too. So it's usually something is, not tolerated anymore. Then that is what brings a patient in. But perimenopause can be 7 to 10 years before that. There's no good number. There's no number that says when is perimenopause. So when is perimenopause? I just saw a patient not too long before today's podcast who is going through perimenopause. And she said she's 44, okay? Average age for menopause is 51, 52 in the United States. So 44, you're what, 6, 7 years from that, right? So that seems like, oh, that's not going to happen to me. But if you check someone's labs, you may get really odd numbers that makes you really confused because she said she went to a functional medicine doctor and they checked their labs and checked her labs. Her estrogen was through the roof, like 1,000. And she's like, how is that even possible? And I said, well, Perimenopause does crazy things. You can check it, can be really high, you can check it, it can be really low. It's such a up and down. It's kind of like you're going through puberty again. Okay, but maybe there's some acne, but um, a little bit different from puberty, right? You don't grow anymore. You're only gonna shrink. But perimenopause, people start to have very classic symptoms are going to be irregularity of their periods. So a period is what allows a woman kind of see part of, look into what's their hormonal status is, but it's not that exact science. There are symptoms like you're getting more fatigue, there's less energy, you're less energetic, you're less passionate about things, definitely less sexual desire. Brain fog starts to set in, you start to forget things. These things start to happen, and you just think, oh, I'm just so busy, because that's what happened to me. I just think I'm too busy. I'm delivering babies back to back to back, and clinic, and then surgery, and then all these things going on, running my practice. I have 3 kids. Okay, it must be I'm just so busy. Until you check your labs and you sit down and look at your symptoms, can you say that, hey, maybe there's something wrong that is making you feel more irritated, more pissed off, more emotional, more hormonal. These are things that really can't just attribute to life.
All right. So thank you for that explanation. And you talked about HRT, which, as I understand it, and I please want you to educate me if I'm misstating this. Typically, HRT is synthetic hormones, but you in your clinic offer bioidentical hormones. Can you explain to our listeners what the difference between those are and what the benefits are of what you offer?
So there's this confusion of what is bioidentical and what's synthetic. Um, the key is a lot of things are bioidentical. Not everything that insurance company covers is synthetic. And so HRT is a general term. Okay, bioidentical just means this hormone is just like how our body makes it. Synthetic, a lot of bioidentical hormones are synthetically made. Okay, so it's not necessarily a two different things. But if the hormone is altered to a point where it's not like how our body makes it,
Then it
that's
doesn't
when
sit right on the receptor. Okay,
or it may cause effects that you do not want.
got it.
So most things, even an estrogen patch is bioidentical. Estrogen itself is a 17 beta estradiol is bioidentical. Um, Premarin is that synthetic. It is synthetically created. It's not my preference. If I get to choose, I would choose estradiol in the form of a, let's say, 17 beta estradiol. But estrogen, like I was saying, estrogen is not as big of a culprit than the synthetic progestin, because progestin is a very different molecule from progesterone, but it sounds so similar. Most people can't tell the difference. But just a little bit of difference, you can see that progesterone is actually really safe, but progestin can have an increased risk for breast cancer. And so if I were to give a patient, and we talk about all different options, we talk about how we want to give it, because what fits in their lifestyle may affect that. Some people won't remember taking a pill every day or a cream every day. Some people want to have something that they just get inserted and they don't think about it for 3-4 months. Some people are very good and very religious about giving themselves injectables and things like that. So everyone's preference has to be considered. But when I talk to a patient, there, for example, estradiol patch, it is covered by insurance. So it's a nice estrogen. But definitely I would pair it with a progesterone. Progesterone is what we make, and so that gives you the highest level of safety and benefit. But estrogen comes in different forms too, and so that's something that can be given differently. Oral estrogen is not as preferable if you have an alternative, okay? Because oral estrogen does have a slight higher risk for venous thromboembolism, so blood clots. And because the way it's goes through your system, it goes through the GI system, what we call the first pass effect. All these things does change the way estrogen ultimately works and the side effect profile. So a transdermal patch, like a estrogen patch or cream or pellet, that's going to be more preferred if if the patient has the access or the option of doing that. Progesterone, I would never prescribe a synthetic unless I have to, and sometimes you have to. You don't always get, it's not a perfect world. And if you have to choose someone being on a synthetic progesterone versus not at all, yes, there may be a slight higher risk for breast cancer, but in the right patient, that's still going to have some benefit compared to nothing. So you're gonna have to balance the two. But one of the things that people don't realize, it's not just estrogen and progesterone. There's testosterone, okay? And testosterone for women is very counterintuitive because it's supposed to be a male hormone and estrogen is a female hormone. But guess what? We have testosterone, we have male hormones, and men have estrogen, right? And so we all have very similar hormones, but then they're in different levels, different proportion, and so it affects us differently. But it is important to know that because testosterone is a very powerful hormone that women tend not to know about. Much less people know about testosterone than BHRT. So yes, I would, really identify the patient's risk factors, talk to them about their preference in how they like to give themselves the medication, their budget, and if they're open to compounding for bioidentical hormones. If they are, let's say, for me, for example, I hate to take a daily pill. That's my weakness. If I'm on a life and death situation, I have to take a pill, I might just die. I just can't take a pill. That's my weakness. So I'm always looking for some things that are not a pill form. So if I have to choose, I would not choose a pill. But most people are fine with pills. So to me, if I were to give myself something, I would definitely avoid a pill. And I will not remember things. I'm going to forget every other day. So for me, I need to find something that works for me, that I don't need to remember this. I don't need to take a pill. But some people, they're very different. Some people are not going to want to self-inject or put a cream on. So everyone differs in their preference. So our goal is to individualize their care to something that they can sustain in the long term.
I understand. So I want to talk to you, because you brought up testosterone, about a recent New York Times article that was about women who were going to specialty clinics and hyperdosing on testosterone and the claims were that it put their libido back into hyperdrive. Women that had no interest in having sex with their husbands now had all the interest in the world and then some. That not only cleared away brain fog, but it gave them hyper focus. Now, these were women with money because these treatments at these specialty clinics were not cheap. But what's your overall medical opinion on hyperdosing on testosterone for menopausal women?
So we have to look at what is considered a reference range. A reference range in the lab. How is that decided? So When people look at labs, they're gonna look at, am I in the reference range? Do I have a red exclamation mark next to my lab, right? Too low, too high. Hormones is tricky because if you look at hormones, the range will vary by what stage of your period are you in. Are you menopausal? Are you in your first half of the period? Or are you in the second half? Because it's hormones so variable. Testosterone. Right now, there's when you look at your lab, the lab range will tell you what's expected, what's average in your age group. But is that normal? That's what hormone replacement is all about. Because if you look at a postmenopausal woman, she's not supposed to have much estrogen. But why are we replacing it? We're replacing it because we're trying to help minimize disease formation. We're trying to help the patient have a good quality of life. Because I always believe in the concept that we're not here to live longer. It's great if we get to live longer, but it better be damn good. Okay, it has to be good quality because I don't want to live 120 and I feel crappy from age 80 on. Then you know what, just give me a pill that I can't swallow. But I think most people feel that way. They're not trying to live longer. If they're going to live longer, they have to be living healthy. And it's not just not disease. You want to go to places, do things where you feel like you're not relying on other people. You're independent. You're not going to rely on a diaper or a pad because you're leaking. Okay. You're not so dry that if your husband tries to have sex with you, you're like, I'm disgusted, or I'm like, I don't even want to hold hands. I don't want to give him signals. You want to enjoy your body's function to the maximum, even if you're at 90, 100. At least, okay, you don't need to be in your teenage year level, but at least you need to have disease-free, moving-free, painless. Okay, all these are so important. And so for women, there's a lot of things that we don't even talk about that people don't realize. We just kind of think that it's normal that our moms has it, grandma has it, so then it's part of aging, but it doesn't necessarily have to be. So when we're dealing with what is a reference range, we're trying to optimize that level in a safe fashion. Okay. So when we're saying hyperdose, it kind of depends. So most people, let's say when they hit mid 40s, 50s, their testosterone is really quite dropped. And like I was saying, everyone started out differently. My baseline might be very low and I drop and it's not a huge drop, but it's undetectable, for example. Someone else, they started much higher and their drop is still low, but then it might all look normal. So I aim for a testosterone level that is actually supra reference range, but in still a safe range that women will have benefit. And these benefits are not just making you, horny. We're not trying to get women, all excited about sex. That is important. Don't get me wrong. That is very, very important. I'm sure we can talk about this in another episode, but sex is such a core component to intimacy in a relationship that it's not just about that, but without that, it can negatively affect the relationship. And if you're not even wanting anything to do with it, you're having pain from it, that's really hard for the woman because most women will do what? They will accommodate. They will be okay because they love their husbands. They're like, I love my partner, I love my boyfriend. So even if it sucks, even if I don't feel anything, I don't have an orgasm, I feel dry, I'll suck it up. I might even pretend. So I think that's the key, is that let's make sure if this is still going to happen, if sex is still going to happen, let's make sure that women are also enjoying it and getting the benefit from it. So yes and no, I think sex drive is definitely a testosterone um, supported function. There's more to it than that, especially for women. But the testosterone that we're talking about, we're not trying to get women into these bodybuilding, transgender level testosterone. No, no, no. And that's a whole different category. But what we're trying to do with testosterone replacement therapy is to get it to the optimal range, not the average expected range, but the optimal range, because that's what anti-aging is all about, right? We're trying to minimize issues. I always give patients the example of glasses. People say, well, how long do you need to be on hormones? You know, well, I'm not treating an infection. I'm not giving antibiotic for a scrape and you get infected. We're actually trying to replace something that you will never have back. So it's like you lose your vision. You have glasses because you can't see far. So most people that have glasses, it's genetic. There may be what you do that can make it worse. But once you lose that ability to see far, if there's no glasses, you're done, right? How do you function? Like, how are you gonna ever function? And then so what do? You give them glasses and then you say, okay, now you can see, okay, now we're done, let's take it off. So you gotta keep it on for that person to function. So if you give someone glasses, you made their problem go away, but that doesn't mean their problem actually went away for good. You need to depend on the glasses.
Okay.
So the same thing is for us for replacement, unless there's something that we will come up with in the future that can make our own testosterone to the level that is significant, not a little bit of improvement. That can be affected by different things, physical activities and different things. But then truly the level that we want it to be, you got to replace it.
That makes perfect sense. I'm so glad you brought up glasses because when you and I were working together, you
Yeah.
gave me a treatment. I was perimenopausal at that time. And if I would eat a meal and then drink a glass of water with that meal, and then later on in the evening, I would laugh or cough, I would have leakage. And you gave me the ALMI treatment, which was based on taking stem cells out of your fat cells and then re-injecting them into you. But that was many years ago. The same way that you said that there's so many women that have a gap in knowledge about hormone therapy, can you tell us about in your clinic some of the cutting edge treatments that have come along for things that women may not even know that there is a treatment for that, and they're sitting there suffering in menopause or suffering post birth, and you have something for them? Tell us about how that has developed and what you're offering, some of your offerings.
So to me, I'm always interested to see what are the advanced technologies that can help with different aspects of changes that women inevitably go through after, well, there are different situations in life, but for example, after birth, there's 100% a woman will never be the same after they carry a pregnancy and childbirth. The younger you do this, the better you can recover to maybe a better state of things. But imagine to carry a 6 pound, 8 pound, maybe 10 pound baby, but then not even including the weight of the water, the amniotic fluid, the placenta, the uterus, all your bodily changes, what that does to your body, all the things that your body has to adjust to make that happen, you can't ever get someone back for good and bad, because there are some things that come through that are beneficial when you get pregnant, when you get pregnant. Delivery, yes and no. Breastfeeding, all these things, they have benefits, but then what comes with it is irreplaceable. So to me, I've always been searching for things that can help for my patients, but also for myself, because I've had 3 kids. So I understand, my oldest is almost 24. And back then, there's nothing. Like, I don't know anything that was really offered back then. And so to me, if we're able to fix so many problems in the world, we haven't really gone back to some of the basic things that women suffer. Okay, so one of them is urine leakage. Okay, if you have someone that has had a child, at least several years out, they may start to have some urine leakage involuntarily. Cough, sneeze, you laugh really hard, you hear a joke. If you have a little full bladder, that may just cause you to leak a little bit of urine. If you're a runner, if you're weightlifting, it's such a confidence killer when you feel like, oh shoot, I peed my pants. You know, you think that might happen when you're a kid, when you're holding your bladder too long, and then you wanted to play so much you forget to go to the bathroom and you peed your pants, right? You don't that's dignity. For a woman to lose that, it's a huge, it's scary. For you to think that, oh shoot, I'm actually getting old. What am I gonna do? Because am I not gonna travel anymore? Am I have to look for bathrooms all the time when I go out? Urine leakage. It's huge in women after childbirth, but menopause makes it even worse. Menopause, the lack of hormones, the lack of estrogen, it dries up our tissue. It changes the way our pelvic muscles work, our mucosal tissue, the pH, the level of collagen that we have in our urinary genital tract, that it's going to allow people to, it leads to more problems, not just the cough and sneezing, but also the urge, the overactive bladder, the irritable bladder. These are going to lead most people to have some level of urinary leakage or inability to control and stay dry. And so that has such strong implication in women's independence. Also, people that are in leadership roles or in executive roles. No one wants to feel like they don't have control, right? And so that's one of the very, very sensitive topic, but it affects so many women. And even people that have never had children have urinary incontinence. So it's not just, right, it's not just for women that have gone through babies. So we're not trying to, just focus on a certain group, but this can span so many people. Vaginal dryness. Okay, even if you don't have sex, some people get really irritated. And with menopause, like I mentioned, all these changes, if you're exercising, you're in tight clothing, it may chafe, it may cause discomfort to the point where you're like, you know what, I gotta see a doctor. But it's even worse when you have sexual intercourse. I just had another patient was saying that, like, she's menopausal, and she said, I don't want to have sex. First of all, I don't have any desire, but it's so painful. Like, why do I want to do something like that? It's like, there's no benefit to me. It's like, it's just bad on bad, right? And so it's like vaginal dryness, and everything starts to atrophy and really shrink, and not just in a good way, but everything's stiff. If you think about it, people complain after birth, everything's loose. Oh, so we want to tighten, but it's not tightening. It's giving you elasticity. You lose that in menopause. And so vaginal dryness, inability to have intimacy in a way that both sides can enjoy. Things that affect women can be even nuances. They never looked at themselves. All of a sudden they take a look. They're like, oh my God, I look like that? Yeah, right. I have so many women. They said, oh my goodness, I think I have some growth down there. It's the first time they looked or touched, and then they're like, oh shoot. And then they come to me and I said, it's been there for a long time. You just never looked. But people that notice that there's changes aesthetically, some people are really bothered by it. Their self-confidence is affected. They don't want to turn on the light when they're having sex. They don't want to look at themselves. Or it may affect them during tight clothing or certain things that really makes them self-conscious. So in our practice, we talk about everything. Our patients close the door, we talk about everything. They tell me about everything. We cry together, we laugh, we talk about everything, women go through. And so all the things that we do, there's so many, but we take care of the function, we take care of the aesthetic look of things. So people that feel like they have dryness or leakage, we have a number of treatment that are cutting edge. For example, radiofrequency treatment for the vagina, or radiofrequency with microneedling. Sounds kind of scary, but it's very powerful for urinary leakage. We also have lasers, CO2 laser, that helps with atrophy for dryness. We inject PRP, so we draw our blood, spin it down, get the growth factors from the platelet, and we inject it into certain areas that help with urinary leakage. What you did was the micronized adipose tissue, so your own fat cells, we micronize it and we process it, and we inject it back into certain areas to help using that stem cell technology to help build your own collagen and to also give more vasculature. And so that in hands will lead to symptom improvement, like vaginal lubrication will be better, more sensitivity, less leakage, more dryness, and also more plumpness. The appearance will be improved, a bit younger appearance. So all these, women really, I think they don't know a lot about this. Only when you maybe start exploring, or maybe you have a friend, you get a couple drinks and your friend spills all her secrets. That's when things kind of start to be talked about.
Thank you so much for giving us that overview. And for our podcast followers, I am going to put a link to Dr. Wei's website in the show notes so that you can look for yourself at her treatments. Again, her clinic is in Irvine, California, in a beautiful building right off of Sand Canyon, off the 405. So, Dr. Wei, please tell me that you will come back for another episode because of your expertise is so on point. You explain it in a way that makes it so clear to people who are not doctors themselves. We just really want to know that we can have you back for further discussion at a later time.
And that's of course a yes. I love to share. And I love that you're taking this into a project that is trying to help women. Because I do think that education is very limited. There is a gap. And you're such a passionate person, and we're so passionate. We want to share our knowledge to women. Maybe they may not have any problems now. Maybe their moms or their friends, maybe their future. But I think that the good news is that there is a lot more attention to women's health. Because in the past, it's all about erectile dysfunction. Now, finally, we have more attention to what we can offer. And so I'm excited, and definitely I will be back.
Oh, thank you so much, Dr. Wei, and thank you so much for speaking with us today. This is Girls Gone Menopause. I'm Adreana Langston. We've been speaking with Dr. Judy Wei, and look in the video description for links to more resources, including her website. Thanks so much for listening.
Thank you, everyone. Bye.